Hi students, hope you all are fine. Today we are going to discuss about heart failure. So congestive heart failure, it is defined as it is a pathophysiological state in which it is the inability of the heart to pump adequate amount of blood to different parts of the body to meet the metabolic needs. Okay, so it is the pathophysiological state in which the heart is unable to pump adequate amount of blood at a rate commensurate at a rate proportionate with the body's metabolic needs. Metabolic needs means the body's oxygen demand, or it is the inability of the heart to pump adequate oxygenated blood to different parts of the body to meet the metabolic needs. So the heart failure occurs when the heart cannot deliver adequate cardiac output to meet the metabolic needs of the body. So etiology of heart failure in fetus. In a fetus, it will be due to severe anemia, that is severe anemia due to hemolysis, fetal maternal transfusion, then supraventricular tachycardia, then complete heart block, then atrioventricular valve insufficiency. Then in a full-term neonate, asphyxial cardiomyopathy, left-sided obstructive lesions like coarctation of aorta. Coarctation means narrowing of the aorta. Then transposition of the great arteries, that means the great arteries like aorta and superior vena cava will be switched to other side. Okay, switched to that means superior vena cava is coming to the right atrium. So at the side of right atrium there will be aorta, and at the side of left atrium there will be superior vena cava. So it is switched. Then viral myocarditis and anemia, supraventricular tachycardia, complete heart block. Then in child to adolescent, there will be rheumatic fever, viral myocarditis, endocarditis, arrhythmias, then cardiomyopathy, acute hypertension, then thyrotoxicosis, core pulmonale. Core pulmonale means it is a reconstruction of the right ventricle of the heart because of pulmonary hypertension. Because of pulmonary hypertension, there will be reconstruction of the right ventricle, and there will be structural and functional changes of the right ventricle. Then chronic upper airway obstruction. So then in premature neonate, fluid overload, then patent ductus arteriosus. We will study the patent ductus arteriosus in the congenital heart diseases. Then ventricular septal defect, we will also discuss the same ventricular septal defect in the congenital heart disorders. Then infant to toddler, left to right cardiac shunts, then metabolic cardiomyopathy, acute hypertension, then supraventricular tachycardia and Kawasaki disease. Kawasaki disease we will discuss in this unit. Then risk factors include hypertension, then hyperlipidemia, diabetes, then coronary artery diseases, family history, smoking, then alcohol consumption and use of cardiotoxic drugs. The factors affecting the cardiac performance are cardiac output depends on the stroke volume and heart rate. The stroke volume means it is a volume that is volume of blood that is pumped from the left ventricle. So stroke volume is dependent on three important factors, that is preload, afterload and contractility. Then the factors affecting the cardiac performance are preload. Preload means in preload there will be volume overload, end diastolic volume. Then the preload such as ventricular septal defect, patent ductus arteriosus or valvular insufficiency. Then afterload means in afterload it is the resistance or pressure against which the heart must pump blood. Example, systemic vascular resistance. In afterload such as with aortic stenosis, pulmonary stenosis or coarctation of the aorta. Then contractility. There will be the cardiac performance depends on preload and afterload. Then volume overload is the most common cause of congestive heart failure in children. And factors affecting cardiac performance are preload. In preload there will be depending on the total blood volume, then venous tone, body position of the child, then intrathoracic and intrapericardial pressure, then atrial contraction, then pumping action of the skeletal muscle. Then in afterload means impedance against which the left ventricle must eject blood. That means because of peripheral vascular resistance there will be afterload. Then left ventricular volume, then physical characteristic of the arterial tree. Then in contractility, that is the cardiac performance independent of preload or afterload because of the less contractility, that is sympathetic nerve impulses, then circulating catecholamines, anoxia, acidosis, then loss of myocardium. Then heart rate depending upon if there is any failure in the autonomic nervous system, there will be if there is any temperature change or metabolic rate. Then compensatory mechanism in heart failure. If there is a heart failure, the body will have some compensatory mechanism. First is cardiac compensation. Cardiac compensation, to compensate the heart failure, the heart rate will be increased, and cardiac contractility, then cardiac dilatation, then myocardial hypertrophy. Then in systemic compensation are increase the blood volume, then redistribution of blood flow, then increase of erythrocyte, then increased ability of tissues to utilize the oxygen. The neurohormonal compensation include the sympathetic nervous system, then renin, angiotensin, aldosterone system, and the atrial natriuretic peptide. That means natriuretic peptide means the kidney starts to eliminate more sodium through urine. Then endothelium. And here, because of the decreased cardiac output, in heart failure there will be decreased cardiac output, so there will be two changes. First is decreased carotid sinus firing. So as a result there will be increased sympathetic discharge, and as a result increased force of blood, increased heart rate, increased preload and increased afterload. Then if there is decreased renal blood flow, okay, decreased renal blood flow, there will be increased renin release, increased angiotensin release, and there will be increased preload, afterload and remodeling of the heart. Then classification of heart failure according to the course of disease: acute heart failure and chronic heart failure. Then according to the severity: mild heart failure, middle heart failure and severe heart failure. Then according to the cardiac output: low output heart failure and high output heart failure. Then according to the location, there will be left-sided heart failure, right-sided heart failure and biventricular failure. Then according to the function, there will be systolic failure and diastolic failure. Then when we have to suspect the CCF: if the child is having poor weight gain, if the child is having difficulty in feeding, if the child is breathing too fast, persistent cough and wheezing, then excessive perspiration, irritability and restlessness. Then if there is puffiness of face, pedal edema or diaphoresis. Then clinical manifestation include, in infants it includes poor feeding, failure to thrive, tachypnea and diaphoresis with feeding. Diaphoresis means excessive sweating. Then older children may present with shortness of breath, easy fatigability and edema. In physical examination, finding depend on whether the pulmonary venous condition, systemic venous condition or both are present. Then tachycardia, a gallop rhythm, a thready pulse may be present with either cause. And if left-sided failure is predominant, tachypnea, orthopnea, wheezing and pulmonary edema are seen. Then if right-sided failure is present, hepatomegaly, edema and distended neck veins are present. Then left-sided heart failure or forward failure. Here the condition occurs mainly in the lungs, okay, from blood backing up into the pulmonary veins and capillaries. The blood will be backing up into the pulmonary veins and capillaries. So in the left-sided heart failure, that means in the left-sided heart failure, the left side of the heart is not functioning, hence the pulmonary vein is not able to transmit the blood to the left atrium. So there will be backing up of blood into the pulmonary veins and capillaries. There will be shortness of breath, dyspnea or on exertion, then paroxysmal nocturnal dyspnea, that is dyspnea at night, then due to the reabsorption of dependent edema that has developed during day, and orthopnea, pulmonary edema, then cough may be dry, unproductive, usually occurs at night. Then fatigability from low cardiac output, nocturia, insomnia, dyspnea, then catabolic effect of chronic failure, then insomnia, restlessness are the manifestation. There will be tachycardia with S3 ventricular gallop. Then right-sided heart failure, that is backward failure. Here the signs and symptoms of elevated pressures and congestion in the systemic veins and capillaries. There will be edema of angles. Okay, that means if the right side is failure, there will be the superior and inferior vena cava are unable to empty the blood into the right atrium. So edema of the angles, unexplained weight gain. That is pitting edema is obvious only after retention of at least 10 lb of fluid. Then liver condition may produce upper abdominal pain, distended jugular veins, then abnormal fluid in the body cavities, especially in the pleural space and abdominal cavity. Then anorexia and nausea from hepatic and visceral engorgement. Then nocturia, diuresis occurs at night with rest and improved cardiac output. Then weakness. Then cardiovascular findings in both types. There will be cardiomegaly, that is enlargement of the heart detected by physical examination and chest X-ray. Ventricular gallop evident on auscultation, that is we can hear the S3 sound. Then rapid heart rate, development of pulses alternate, that means alternation in the strength of the beat. Then clinical history includes the neonate and infant, there will be poor feeding, tachypnea worsening during feeding, cold sweat on forehead, and poor weight gain. Then older children, fatigue, exercise intolerance, dyspnea, puffy eyes and pedal edema, growth failure. Then on physical examination, the initial examination, there will, in right-sided heart failure, there will be hepatomegaly, facial and pedal edema, jugular vein engorgement. Then left-sided heart failure, there will be tachypnea, tachycardia, cough, wheezing and rales. Then either side failure, there will be cardiomegaly, gallop rhythm, cyanosis, low volume pulse, then absence of weight gain. Then in chest X-ray, there will be chest cardiac enlargement, pulmonary edema. In 12-lead ECG, we can see the variation in the rhythm of the heart. Then pulse oximetry, then hyperoxia test, echocardiography, CBC, then electrolyte, calcium, creatinine, LFT, blood test and thyroid function. In diagnostic evaluation in echocardiography, two-dimensional with the Doppler flow studies may show ventricular hypertrophy, dilatation of the chambers and abnormal wall motion. Then ECG resting and exercise may show ventricular hypertrophy and ischemia. Then chest X-ray may show cardiomegaly, pleural effusion and vascular congestion. Then cardiac catheterization to rule out the coronary artery disease. Then ABG studies may show hypoxemia due to pulmonary vascular congestion. Then liver function test may be altered because of hepatic congestion. Then human B-type natriuretic peptide, that is, as the volume of pressure in the cardiac chambers rise, the cardiac cells produce and release more. That is B-type natriuretic peptide. So cardiac walls, it is a release because of the high volume and pressure in the cardiac chambers, the cardiac cells produce B-type natriuretic peptide. This test aids in the diagnosis of the heart failure. This B-type natriuretic peptide is the presence of B-type natriuretic peptide in the blood is indication of heart failure. So this test aids in the diagnosis of heart failure. Then the level greater than 100 ml is the diagnostic for heart failure. In addition, the higher the BNP, the more severe the heart failure. And BNP is used in emergency department to quickly diagnose and start treatment. Then imaging studies like chest X-ray for cardiomegaly, ECG for arrhythmia. Then an echocardiogram assesses the heart chamber sizes, measures the myocardial function accurately and diagnoses congenital heart defects when present. Then complications are intractable or refractory heart failure becomes progressively refractory to therapy. Then cardiac dysrhythmias and myocardial failure and cardiac arrest, digoxin toxicity from decreased renal function and potassium depletion, and pulmonary infarction, pneumonia and emboli. Then drug classes, first is diuretic, to eliminate the excess body water and decrease the ventricular pressure. A low sodium diet and fluid restriction complement this therapy. Then positive inotropic agents increases the heart's ability to pump more effectively by improving the contractile force of the muscle. The inotropic agents are digoxin or lanoxin. It may only be effective in severe cases of failure. Dopamine or intropin improves the renal blood flow in low dose range. Then dobutamine, then milrinone and amrinone are potent vasodilators in afterload. Then vasodilator therapy decreases the workload of the heart by dilating the peripheral vessels. Example are nitroglycerin, then hydralazine, prazosin, sodium nitroprusside, morphine. Then AC inhibitors inhibit the adverse effect of angiotensin II, decreases the left ventricular afterload with a subsequent decrease in heart rate associated with heart failure, thereby reducing the workload of the heart and increasing the cardiac output. They may decrease the remodeling of the ventricle. Then beta adrenergic blockers like norepinephrine, that is, it decreases the myocardial workload and protect against the fatal dysrhythmias by blocking the norepinephrine effects by the sympathetic nervous system. Then angiotensin II receptor blockers similar to AC inhibitors, it is used in patients who cannot tolerate AC inhibitors due to cough and angioedema. Then aldosterone antagonist decreases the sodium retention, sympathetic nervous system activation and cardiac remodeling. Then spironolactone is an aldosterone antagonist or aldactone, it is most commonly used. Then human B-type natriuretic peptide used in patients with decompensated heart failure. It produces smooth muscle cell relaxation, diuresis. And treatment principles include correct the underlying causes of heart failure. Next is diet, low sodium, low salt and high calorie diet. Then digitals, improve the cardiac contractility. Then diuretics reducing preload and furosemide. Dilators reducing afterload and EC. So remember this 4 D's in the treatment, that is diet, digitalis, diuretics, dilators. General measures are propped up position, provide propped up position, oxygen, adequate calories should be provided, salt should be restricted, provide adequate bed rest, check the daily weight, then management of respiratory failure. Then treatment of heart failure, general care means rest, Rest reduces the cardiac output. Then oxygen improves the oxygenation in presence of pulmonary edema. Then sodium fluid restriction decreases the vascular congestion and decreases preload. Then other are transplantation, removes diseased heart. We can do heart transplantation. Then carvedilol, that is, it is a beta blocking agent. Then diuretics reduce the preload. That is furosemide, salt excretion by ascending loop of Henle, reduces preload, afterload, reduced if hypertension improves. Then combination of distal tubule and loop diuretics. Then inotropic agents like digitalis and dopamine. Then dilators reduce the afterload like hydralazine, nitroprusside and captopril. Then other inotropes are phosphodiesterase inhibitors like milrinone or amiodarone, low cardiac output refractory to standard therapy. Then adrenergic agents like dopamine, dobutamine. The nursing assessment, obtain history of the symptoms, limits of activity, response to rest and history of response to drug therapy, assess the peripheral arterial pulses, note quality, character, assess the heart rhythm and rate of BP, assess the edema, inspect and palpate precordium for lateral displacement of palpate the precordium, that means chest cavity. Then obtain hemodynamic measurement as indicated and not change from baseline. Then assess weight and ask about baseline weight. Then note result of serum electrolyte level and other laboratory tests. Then identify the sleep pattern and sleep aids commonly used by the patient. Nursing diagnoses are decreased cardiac output related to impaired contractility and increased preload and afterload. And impaired gas exchange related to alveolar edema due to elevated ventricular pressures. And excess fluid volume related to sodium and water retention. Activity intolerance related to oxygen supply and demand imbalance. So these are the nursing diagnoses. And I hope you all understood the classes well. If you have any doubt, you can ask me in the. Thank you.